Well, let's move on to newly diagnosed myeloma in the transplant-eligible patient population. Tom, why don't you get us started off on how do you choose between commonly currently used approaches, BRD, KRD, just get the ball rolling.
Yeah. So this is one thing that I really like about being a myeloma physician is before I walk into the patient's room, I really don't know what I'm going to give them for therapy because I do think we provide personalized therapy.
Many might not find that reassuring.
Which is great. Now, in fact, the choices are getting smaller and smaller, especially for transplant-eligible newly diagnosed patients. I think we have two options, lenalidomide, bortezomib, and dexamethasone, or RVD, and carfilzomib, lenalidomide, dexamethasone, or KRD. We're not at for the transplant eligible, we're not at adding the antibody just yet. But in terms of those, I would say that the majority of my patients I treat with RVD. It provides an excellent overall response rate, greater than 95%. We get CRs in the 30 to 40% range, and in MRD negativity, 10 to the minus fifth, in upwards of 40 to 50% of patients. It's a very good regimen. I would say that our bias, or my bias in general, has been if I have a really young patient or if I have a patient that has a high-risk cytogenetic profile, and that for me it does include 414s, 1416s, 17p deleted patients or multiple cytogenetic abnormalities. I then do give them carfilzomib, lenalidomide, and dexamethasone, or KRD. So for me, it's RVD versus KRD, with KRD winning in the young and really strong, and also the patients that have high-risk disease.
Okay, Karina, I know that you take a slightly different tack in Houston. You want to talk to us about for the regular generic patient that walks in?
Sure. So you have to prove yourself not worthy of KRD. You have to have cardiomyopathy or something that tells me, hey, carfilzomib's probably not going to be the right drug for you. Of course, all our high-risk patients, and sometimes even our frail patients that are high risk, we are able to do carfilzomib or dex. Biggest reason, I think the neuropathy. We do see a lot of neuropathy with Velcade, and with carfilzomib, it's a lot less. I think I've had 1 or 2 patients in all the patients we treat. And I think how quickly the carfilzomib works, right? I do have a lot of patients with high risk, but also bulky disease that just didn't know they had myeloma until something bad happened, and they have a lot of disease, pain, bone pain. It seems to get it down really quickly. I'm usually able to decrease the amount of cycles I need prior to transplant. So yeah, the majority of our patients get KRD.
Okay, other comments on sort of current state of the art before we walked into ASCO?
I think, the antibody is sort of inching its way into the front line, and I would imagine many of us do add it on, maybe not routinely, but if we're unhappy with the response with RVD, I certainly very quickly either switch to KRD or I, based on the Griffin study, I add daratumumab because you, again, see deep, quick responses, and the tolerability is quite excellent. I guess the other point I would make that I did before coming into ASCO, in fact, had a discussion about the Forte data and the role of stem cell transplantation up front. And there was a lot of hand-wringing now that, the comments that made that response rates look similar in the KRD12 versus the KRD plus transplant. But I left the session this morning actually quite reassured about the role of stem cell transplantation, given the higher rates of MRD negative in the transplant arm.